The 0 Point Survey is a checklist of non-clinical factors, including self, team, and environment, that one goes through before doing the primary survey on a patient. This is a way of optimizing your preparedness for a mission in or out of hospital. The components of the 0 Point Survey are self, team, environment, and then patient. And what I want to do in this talk is to offer a conceptual framework in the form of a mind map to help you understand and recall these components. I'm going to go through it quite quickly, but there'll be opportunities later to discuss the components in more depth. So in terms of self-preparation, we need to think about physical and psychological preparedness. On the physical side of things, we use an I'm safe checklist borrowed from our aviation colleagues. The components of that include illness, so not going to work when you're sick, something we've all learned thanks to the COVID pandemic, not being medicated in a way that will affect our performance, understanding the effects of stress, avoiding alcohol and other recreational drugs and their after effects, being mindful of fatigue, and eating and elimination. Elimination meaning weeing and pooing. So making sure you follow the full stomach, empty bladder mantra, which is something most of us have learnt the hard way to avoid. Now, some of those are obvious, like not turning up to work drunk or stoned, but some are a little bit more hard to control. For example, everyone watching this has at some point been stressed or tired. For some people, that's just called Tuesday. What do we do about that? Well, we need to encourage work environments where we can acknowledge those factors and discuss them openly and say to our colleagues, I'm tired today. It might be affecting my performance. If there's an opportunity to get some rest, I'm going to do that. And if you've got the kind of people that watch your back, then as a team, your output can be maintained. But if, as an individual, if you keep it to yourself and underperform, there's a patient at the end of that process that could come to harm. So that's a useful quick checklist on the physical side. On terms of psychological preparedness, I break it down into 3 ways in which our brains interact with the challenges of a scene or mission or patient encounter. There are the stress or emotional components, the cognitive components, and the perceptual components. The stress and emotional components refers to the subconscious process of performing a threat challenge appraisal, which is when your brain works out whether it thinks you have the resources to deal with the challenges of the job or whether your resources will be overwhelmed. If it's the latter case, you initiate a threat response, you get an adrenaline rush, and you feel stress, you feel anxiety, and that can impair performance. And the way we control this stress response is by using psychological tools, which boil down to breathe, talk, see. Breathe is using combat breathing or square breathing or controlled breathing to bring down your respiratory rate consciously, which can then have a positive effect on bringing down your heart rate and reducing the stress response, widening your awareness, and bringing your emotional response under control. This then buys you time to use your metacognition, your ability to think about your own mental and physical state. And you can then reassure yourself using positive self-talk internally that you have the resources to deal with this encounter. You might say to yourself things like, I've got this, or we've got this, or this team is well trained, or I'm well equipped, or I know the standard operating procedures for this situation. We will be fine. And then C refers to visualization, which is the successful completion of an outcome or procedure in your mind's eye. So an example of employing all of these might be if I'm on my way to a pre-hospital head injury of a very young infant and the crew on scene have said there's a difficult airway, I could potentially think, well, when did I last intubate a small infant with a difficult airway? That might have been many months ago in my clinical practice, and I might start to notice that I'm anxious. So having that ability to use metacognition to notice this mental state means I can start to use these tools. So I might be on a road response with a critical care paramedic, and as we're traveling on lights and sirens in the ambulance, I then close my eyes and I do some combat breathing to calm myself down, and that buys me the ability then to do some positive self-talk. Right, I'm with Phil, he's an excellent critical care paramedic, we're well trained for this, we know the SOPs, I have my pediatric reference drug cards, and we've simulated this very recently, and I've done successful pediatric intubations in the past. This is going to go fine, and now I'm going to visualize in my mind's eye the successful passage of the laryngoscope, controlling the large tongue and the large epiglottis, which I expect to see. We've got the patient adequately positioned and muscle relaxed and pre-oxygenated, and there are the cords, and the bougie and tube go in, the cuffs inflated, the bougie's out, we connect end tidal CO2, and we've got a nice waveform, good chest rise, good sats, the team's happy, the parents look reassured, everything's calm, and I'm now feeling good. I've controlled the stress response with Breathe Talk See, and I now can open my eyes, and as I do so in the ambulance here, the paramedic says to me, "Cliff, this is the last time I let you drive the fucking ambulance." I go, "Sorry mate, I was just having a moment there, but I'm good to go now." So that's how you can use these psychological tools, Breathe Talk See, to or beat the stress, as a way of remembering it, to reappraise a threat as a challenge. Your mind understands you have the resources to deal with it, switches off the stress response. You can switch into a performance state. Let's consider the cognitive aspects, by which I mean how much can your mind take on and do at once. We know that as we try to multitask, those individual tasks deteriorate in quality. We've got limited bandwidth, and as it fills up, we become less effective. And what we need to do to preserve bandwidth is, again, use metacognition, recognize what's going on, I'm feeling overloaded, and start to offload and delegate and avoid taking on more tasks, which is easier said than done. But the interesting thing about bandwidth is if it completely fills up, you no longer have any remaining bandwidth to notice that your bandwidth is full, and you can cease to function. Now, we can multitask when we have automated those tasks. If we're experienced drivers, we can have a conversation or listen to a podcast while we're driving because we've automated the task of driving. But a brand new learner driver can't do those things. And the more we can automate and cognitively offload, the more we preserve bandwidth. So using checklists is effective for cognitively offloading. Following policies, protocols, knowing your SOPs inside out preserves bandwidth. And knowing how to use your equipment and having trained with it regularly preserves bandwidth. And finally, simulation. Even running the virtual reality simulator in your own brain to go through scenarios so that when they turn up, for example, a surgical airway, you've done it 1,000 times in your mind, you crack on and can do it with ample remaining bandwidth available. On the perceptual side, we're thinking about situational awareness. What are we doing? And while we're doing that, what are we not seeing, or what are we not noticing? Because if we become task-focused, we become blind to other stimuli. And a great example of the extreme ends of this, thinking in evolutionary terms, is with prey and predators. The gazelle as prey is something that is hyper-vigilant for threats. It's picking everything up. Was that a lion I heard? The wind in the bushes, is that a cheetah? Oh my gosh, I'm going to get eaten. So it's very sensitive but not very specific. It's hyper vigilant. That's how you want to be when you're a team leader. Pick everything up, not miss important things. The cheetah is a task-focused proceduralist pouncing on the gazelle. It might not notice while it's doing that other threats, like a poacher with a rifle pointed at it. So it's highly specific but not very sensitive. And in a clinical setting, we may well need to flit between cheetah and gazelle mode, or between predator and prey mode, depending on whether we've got the overview of the scene or whether we are task-focused. We may need to hand that off with closed-loop communication. So that's our physical and psychological preparedness for self as part of the 0-point survey. Let's go on to team factors. And the optimal structure of a team has a team leader and team members. And the way that this is successful is if those members and leader share a mental model about what's going on. A team has to perform together to achieve an outcome. And it can only do that if it knows what the outcome is and how to achieve it. And so this is where the next part of the 0-point survey comes in. We've got step and then we have up. When the mission is underway, we need to regularly share an update of the patient status and the plan about what we want to do next, or priorities. And we're sharing mental models of task work, what needs to be done, and teamwork, who's going to do it. Guaranteed, this is the number one factor, if you get good at this, that will improve your missions and improve your teamwork and improve your simulation. If people aren't regularly announcing what's going on and what the plan is, you get divergence of activity and breakdown of the team structure and increasing entropy. You need to bring it back together with these regular updates and sharing of mental model. Let's think about communication within that team. There are different communication styles we should adopt. Closed loop is important for not making errors like drug errors, and ensure that what is said is heard and understood by repeating it back and confirming it's been repeated back correctly. Ideally, we'd use standard terminology, a standard lexicon. Disregard means forget what I just said, for example. Roger or copy means you've understood what's been said. And getting in the practice of using standard terminology reduces uncertainty and ambiguity, particularly in a resuscitation life-threatening situation. You need to be crystal clear and communicate quickly, and avoid the use of too much mitigating language, which is when we embed all the social graces and avoidance of upsetting anyone by being overly polite. For example, saying, it would be awesome if you could think about possibly passing me the salt when you're having dinner, rather than rudely just saying, give me the salt. But in a resus situation, sometimes you need to say, give me the salt, or its equivalent, and that's okay. That should be understood by the team. Now, what we want to avoid at all cost is conflict between clinicians. When there is conflict between clinicians, the patient always loses. So how do we avoid conflict? We do that by learning how to communicate effectively so people feel like they're on board with what we're suggesting. It's a kind of mind control. I like to call it guided cooperation. And in essence, the components of it, number one, are to be nice, to be good. Don't be a dick. If people like you, they're more likely to do as you ask and want to help you. The next rule number 2, is make every statement about the patient, your concerns, what you think should be done, rather than about the other clinicians or their plans, because that will reflect on their competence in front of other clinicians. For example, if I arrive on scene as a pre-hospital physician and someone is handing over the patient to me, and I say, right, good, thanks for the handover, looks really sick, let's move him over to that rock platform over there and intubate him, and then we'll tidy up the splintage and get going. If the paramedic on scene says, no, you don't want to do that, doc, we've got to get control of his hemorrhage first, that paramedic may be completely right. But what's happened there is the way that they've said that, they've challenged the plan of another clinician in front of other clinicians, the patient, their family, for example. And the way humans often react to that challenge is to double down, because they fight to preserve their feeling of competence, of control. And this is a subconscious thing. It's not necessarily their ego getting in the way. It more boils down to their professional identity and their feeling of what they stand for that's being challenged. And so they will then become oblivious to information that actually tells them their plan wasn't a great plan. So just by choosing the language, by being tactical with language, the handover could have gone something like, right, nice one, let's get him over there and intubate him, and then we'll tie up the splintage. And the treating paramedic might say, sure, doc, we'll help you with that intubation in a moment. Good idea. First, are you happy to just have a look at this hemorrhage control issue we've got here? We'd appreciate your help with this. And they've said exactly the same thing. Let's not intubate him until we've got hemorrhage control. But they've done it in a way that has taken the doctor along with them. They've done an initial agreement. Yeah, sure, doc, we'll help you with that. And first, can you help us with this? They've kind of guided them and led them to where they want to go without any kind of contradiction or clash. It's very sneaky, it's tactical, but it works beautifully. So think about agreeing with someone first, even if you're kind of disagreeing with them, saying and then pushing them along to where you want to lead them. So that's rule number 3, is find agreement. Don't focus on what you're disagreeing on, focus on what you're agreeing on. Yeah, he needs to be intubated, great one. And before we do that, can you help us with this hemorrhage control? Sometimes the stuff doesn't work. Sometimes you are against authority. You may be unlucky enough to encounter someone who appears belligerent that day, doesn't like your plan, wants to get going, wants to just leave the scene, is focusing on scene times, and you're worried about a patient's airway. What do we do about that? We need to use graded assertiveness. My favorite example of graded assertiveness is the CUS system, which stands for concerned, uncomfortable, safety, and stop. Ideally, you start at the top with concerned. The way this works is you are stating your concerns about something. People can't argue with the fact that you've said you're concerned. You own that feeling, but it does force them to listen to what you're concerned about. I'm concerned about this airway. I don't think we should leave the scene until we've secured the airway. Can you please help me with that? No, let's go. I'm uncomfortable moving a patient with an unprotected airway who's already had one vomit. Let's work together to secure this airway. No, come on, let's move. This is a safety issue. We're going to work together to secure the airway before we move. And if they start moving the patient, you can say, stop. No one's moving this patient till we've got control of this airway. I'm sure you'll agree if you have a look. He's at a big aspiration risk. So the idea is you do work down from the concern to the stop, but sometimes you might have to begin with stop in a time-critical situation if something dangerous is about to be done to the patient. Let's look at environment. Now, when we learn about managing the environment, when we're studying pre-hospital care to train to be a paramedic or pre-hospital physician or flight nurse, for example, then scene safety is often stressed. And that's absolutely right. We don't want to get killed and we don't want to get other people killed. But there are other components like space control. And expert paramedics have been shown to manage their workspace pre-hospital far better than novice paramedics. It's a key component of paramedicine, of pre-hospital emergency medicine. So ideally, the more a patient needs to have done to them, the more you need 360 degrees of access. But everything's a compromise. Sometimes you may need to sacrifice that in the interests of time criticality or scene safety to get away from a hazardous scene. But ideally, you want 360 degrees of access. When you don't have that, if you try to manage a patient stuck in a corner, this can happen in a hospital cardiac arrest or medical emergency team. If someone's had a collapse in the bathroom in the orthopedic ward and they might be a super obese patient post-knee surgery, they've had their massive pulmonary embolism, they're stuck in the toilet cubicle unconscious, possibly not breathing, with a barely palpable pulse, the junior medical and nursing staff may actually steam into that cubicle, start attaching monitoring and oxygen, asking the intern to climb in and put an IV catheter in, and then they want the defib in there, and it's becoming more and more dangerous as more and more stuff gets sucked in. And I like to think about this as a kind of analogy with gravity. The more mass you have, the more gravitational force there is. And what happens is the more people and equipment get sucked into that space or get put into that space, the more it seems to attract more people and more equipment, and it starts getting crazy. And what can sometimes happen is a more senior person or someone with pre-hospital experience will come in, they'll walk into the room, they'll notice there's a corner of the room that's a little bit darker than the rest of the place because light is now having trouble escaping from that corner because of the gravity. And they, in their mind's eye, certainly this happens to me, in my mind's eye in a scene like that, I don't want to get too close. I imagine this dotted line, a perimeter that I call the event horizon, and I know I mustn't cross it, otherwise I'm in there forever. So I stay outside the event horizon, I'll get a stretcher or a bed, and I'll say, right, guys, when you're ready, we'll work together to move that patient out onto this bed. And they'll say, but we think she's not breathing. And I'll go, good, I've got a bag valve mask device here. I'm not sure there's a pulse. Good, because we can defibrillate her safely out here. We can't do that in there. So when you're ready, on 3, we're going to move the patient. So it's insisting on moving the patient away from the things rather than stuffing all the things into the space where the patient is. That's a key component of expertise in pre-hospital care and resuscitation in general. So safety, space. The next one is heat. Are the conditions too hot or too cold for me or my patient? Light. We know when it's dark we need external light sources, but certainly where I work in Australia, In the daytime and in summer, it can be way too bright to see down an airway when you're doing laryngoscopy unless you orientate the patient in the right direction relative to the sun or someone is holding up a screen. Noise is important. So if we've just extricated a patient from a vehicle, then we no longer need to cut the vehicle. We no longer therefore need the cutting tools, and therefore we can switch off the generators and hear ourselves think. So being aware of what excessive noise is there and controlling it is important. And of course, crowd control is important too, both in and out of hospital. It's good to have a red line in the resus room and make sure non-contributors are standing behind the line. And similarly, in your workspace pre-hospital, we need to manage crowds. And more importantly, in pre-hospital, we need to know whether the components of that crowd are friendly forces or hostile forces, and how we are going to control and contain the hostile forces. So these are all things going on in the mind of experienced paramedics that isn't really taught anywhere in a structured way. But I offer to you at least this little simple framework of safety, space, heat, light, noise, and crowd to go through when you're on your way to and arriving on a scene as part of your 0-point survey. So let's say we have optimized our physical and psychological preparedness. We're in good physical shape. We're controlling any stress responses with the tactical psychological tools. We're minimizing the occupation of our bandwidth using our SOPs and checklists and being thoroughly familiar with our equipment and knowing that we've simulated these scenarios in the past. We're mindful of whether we're becoming task focused, and we're handing off the overview of the scene if we're moving from a team leader role to a proceduralist role. Are we a cheetah? Are we a gazelle? And are we handing over those roles? We're optimizing our team by having an appropriate structure with a recognized team leader and team members who encourage that team leader to share regular updates about patient status and what the priorities are. We know what needs to be done and who's going to do it by sharing those mental models. We avoid conflict at all costs by guiding cooperation, by just being generally professional and courteous while being assertive and making all our statements about the patient, not about the other individuals or their plans. If there's potential for disagreement, we focus more on what we agree on rather than what we disagree on. If we do have to face someone with authority that we disagree with, we will use a structured graded assertiveness tool like the CUS system, going from concerned through to stop. All the time, this communication will be in a closed loop fashion, confirming that what's been said has been heard and understood by getting it repeated back to us and confirming that it's been repeated back correctly. And we will practice as teams to use a standard lexicon, so we minimize excessive flowery language and particularly the mitigating language that's unnecessary in a crisis situation. On the way to the scene, we're thinking about hazards and scene safety with our appropriate PPE. When we get to the scene, we optimize space control and provide 360 degrees of access for our patient, minimizing the effect of too much or too little heat, too much or too little noise and light, and controlling noise and crowd control, that space control that makes the expert pre-hospital provider. We don't get sucked into a high gravitational field. We stay outside the event horizon and get the patient brought out to a safe workspace. Let's say we've done all that. Our 0-point survey has gone swimmingly, but sometimes still the job feels bad. The mission was something that left us feeling not too good about or even sad about. And that's because patients are sometimes hard. The job is hard. Situations with little kids that are really sick or dead is sad and difficult and increases the stress. When you have pregnant patients who are critically ill, you've got more than one patient to deal with. That's a high stress situation. Patients with very high BMI are very difficult to manage in terms of airway, breathing and ventilation, vascular access, extrication, handling. Everything's difficult. It's just not pretty when you have a very high BMI patient. And all the other ducks can be in line. You can get everything else sorted, but it can still feel like a difficult job because it is hard. And then, of course, frickin' COVID with PPE, difficulties in recognition of who's who and communication, and obviously concern for your own safety can really increase the stress and difficulty. So this was about non-technical skills or the human factors, the self-team environment, the update and the plan. But bear in mind there are patients on a given day that are going to leave us feeling bad or sad despite our best efforts. That is something that we need to acknowledge. That is something that we need to appreciate, that we're all human And in many parts of the world, pre-hospital providers, particularly paramedics and other EMS personnel, are under-rewarded financially and in other respects. And the first rule really is to be kind to yourselves and kind to each other, and forgive yourselves when a job does not look perfect. And don't be that Monday morning quarterback criticizing your colleagues because you heard a job didn't go well. If wherever we work, we can start to foster a culture where we want to learn from each other's experience in a non-judgmental way, we'll exponentially increase our own mental database of cases. If all of our colleagues are encouraged to discuss with us the jobs that went not so well as the jobs that went well, we learn from that too. We all learn from each other, and we all get better quicker. So on that final note, with that self-compassion, which is so critical in the work we're doing, particularly at this difficult time in so many places around the world, please have a think about how you can integrate the 0-point survey into your practice, how you can use this structure, this conceptual map, to help you teach it to your junior colleagues so that they don't make the mistakes we've all made over the years in learning and honing this stuff. And please have a think about how you might add to this or improve it or take stuff away to make it an even more useful tool. Thanks very much for listening, and feel free to contact me by Twitter or YouTube or email or whatever means you know. Thanks again for listening.